Hi, welcome to our March seminar as part of the Prevention Research Center for Healthy Neighborhoods seminar series. Before we get started, just a few logistics and housekeeping for today's seminar. We recognize that in this format, you can't see who all is on the call. If you could please use the chat feature to write down your name and organization to let others know who is here and joining the presentation, we'd appreciate that. For questions, we ask that you please use the Q&A feature. Also, there's a raise your hand feature, which you can use during the question and answer periods if you would like to request your microphone be unmuted. We're excited to have Dr. Leslie Cofie at our seminar today to present on the relationship between social networks and cancer screening among Black immigrant women. Dr. Leslie Cofie is an assistant professor in the Department of Health Education and Promotion at East Carolina University, where he has been a faculty member since 2018. He completed his PhD at UNC Chapel Hill, Gillings School of Global Public Health. He received both his MA in medical anthropology and MPH from Case Western Reserve University. The core of his research focuses on understanding and addressing the root causes of health inequities experienced by vulnerable populations. He examines disparities in chronic diseases between foreign-born and US-born individuals, with a particular focus on cancer control and prevention. Specifically, he studies ways in which socio-ecological determinants of health, such as social networking characteristics, may inform cancer control intervention strategies. Dr. Cofie uses both qualitative and quantitative research methods in developing, implementing, and evaluating a range of health issues. His work has included studies on racial ethnic disparities in little cigar use among adolescents, quality improvement interventions to promote maternal and child health services use in Ghana, evaluation of a patient navigator program to improve HPV vaccination among low-income, racial, ethnic minority, and immigrant serving clinics in Southern Texas, and an intervention to promote health literacy among migrant farm worker families in North Carolina. I'd like to welcome Dr. Cofie today.
Thank you, Sarah, for that nice introduction. I'm gonna go ahead and pull up my slides and get started. I don't know if you're able to see this. Are you able to see the slides?
No, we're seeing your Zoom launch window right now.
Oh, okay. So I think, bear with me for one moment. I last minute switched these slides. There we go. All right. So how about now? Does that work?
No, we're just seeing your ECU background, Leslie.
Okay. I have multiple screens up here, so that may be the issue. Let me stop sharing and try again. Are you able to see it now?
No, it's showing the browser window.
You know, we just tried to make this. I think this bear with me for one moment. All right, let's try this one last time. I think it should work this time. Okay. Yes, no, is it working?
Yeah, we see your slides, but it's not in presentation mode yet.
Okay, perfect. Now,
Now we're on.
all right. So apologies for that hiccup, but I think we're back in business. So I thank you again, Sarah. I would like to begin by essentially, showing you my presentation outline. So here, I basically want to point out that while this presentation is really focusing on the cancer experiences and more specifically cancer control or cancer screening experiences of Black immigrants, and especially as it relates to the relationship between social networks and cancer screening, I really designed this talk to sort of highlight some of the challenges that I experienced while collecting this data, especially in the time of the pandemic. And so I hope that as I go through this presentation, some of the challenges that I experienced would be sort of apparent, and hopefully towards the end of the presentation or after the presentation, we can maybe have a little bit more discussion about the challenges in collecting data among a hard to reach population. So I will begin by talking about the cancer experiences in general of foreign-born individuals. We know that the foreign-born population makes up about 14% of the current total US population. This represents about a threefold increase since the 1970s. These foreign-born individuals oftentimes are from regions with elevated cancer risks. And this is often due to the rapid socioeconomic development in countries such as low to middle income countries, and also the aging population. Also, these countries also tend to have limited healthcare infrastructure, which means that foreign-born individuals, even prior to migrating to the United States, oftentimes have limited cancer knowledge or access to cancer control prevention program or services. So once they migrate to the United States, not only are they faced with challenges to navigating the US healthcare system, but because of their prior experiences or lack thereof in their previous country, they definitely have the added burden of figuring out what is cancer control, the importance of cancer control, and being able to access cancer control services. So more specifically, we know that foreign-born individuals generally have better cancer morbidity and mortality compared with their US-born counterparts. This comes as not much of a surprise because the literature has pretty much shown that foreign-born individuals upon initially migrating to the United States oftentimes have better health status than their US-born counterparts. But more specifically to cancer, previous work research has shown that foreign-born individuals have about 31% lower cancer mortality compared with US-born individuals. Recent work conducted using the mortality data from the National Centers for Health Statistics and also the American Cancer Surveys has shown that cervical cancer mortality, for example, is much lower among foreign-born women compared with US-born women. Some nuances in these findings actually suggest that the rates are higher among foreign-born older women. But here it's important to know that this healthy immigrant effect, which is the better mortality rates among foreign-born individuals, tends to decline as foreign-born individuals live here in the US. So over time, their health status in terms of cancer experiences begins to mimic that of their US-born counterparts. So although immigrant health research in general has shown that the health of foreign-born individuals tend to be better and declines over time, we know that research in this area is lagging to the extent that there's a need to continue to better understand the disease etiology of foreign-born individuals, and more importantly, underlying social cultural factors that may be at play in better understanding the experiences of foreign-born individuals that ultimately lead to the decline in their health experiences. More specifically for foreign-born Blacks, Black immigrants make up about 10% of the US Black population, which represents about 4.5% of the total US population. Recent US census projections suggest that the Black immigrant population will make up about 17% of the US Black population by 2060. Here, it's also important to note that research among Blacks in general has well established sort of the experiences of cancer related factors or cancer experiences of Blacks in general in the US. So we know that it is well established, the cancer survivorship, incidence, mortality, risk, prevalence, and determinants of cancer among Blacks in the US in general. But the reality is that Blacks are not a homogeneous population, although most of the studies tend to group all Blacks together. The part of the reason is that the national cancer surveillance programs that exist oftentimes overlooks the heterogeneity that exist among Black immigrants. Although these surveillance programs tend to identify unique differences that may exist between Hispanic or Latinx populations, and to some lesser extent, Asian immigrants as well. But also the available studies that have looked at the experience or the cancer experiences of Black immigrants in the past. Primarily, there are about 3 studies. For the most part, 2 of the studies suggest that particularly Haitians and also Jamaican immigrants tend to have lower overall cancer mortality. More recently, a study that examined the experiences of Caribbean-born and African-born Blacks compared with US-born Blacks had found that US-born Blacks tend to have higher cancer mortality than the Black immigrants in the sample. So here it is important to point out that the examination of cancer incidence and mortality patterns among immigrants, and specifically Black immigrants, are really important for 2 main reasons. First, it helps us identify risk factors or determinants that may be unique to the experiences of different groups of Black immigrants, or of Blacks in general, and in our case, Black immigrants. And secondly, too, it is helpful in informing the development of relevant cancer control interventions. So here, by cancer control interventions, or cancer control in general, I'm referring to early detection, such as cancer screening. So the question is, what do we really mean by cancer screening? Well, we know that in the United States, early cancer screening of the most commonly detectable cancers, such as breast cancer, cervical cancer, and colorectal cancer, are considered an effective clinical preventive measure for reducing disease incidence and prevention. However, we also know that the screening adherence rates for the general US population is actually below the national goals as set by the previous Healthy 2020 and also national cancer organizations such as the American Cancer Society. In the case of immigrants, more specifically, we know that immigrants have lower cancer screening rates compared with their US-born counterparts. To be even more specific, particularly among immigrant women who make up more than half of the immigrant population in the US, they tend to have extremely low rates of cancer screening. So to provide you with some example from the National Center for Health Statistics, as you would see in this table, we see that breast cancer screening, cervical cancer screening, and colorectal cancer screening rates are much lower among immigrants compared with with their US-born counterparts. Here, I also note that immigrants that have lived in the US for 10 years or more tend to have higher rates of screening compared with those who have lived here for less than 10 years. Although, again, the rates for immigrants in general are much lower than US-born counterparts. In terms of Black immigrants, some studies have also shown that there are lower screening rates in Caribbean-born Blacks and also African-born Blacks. Here, it's important to know that a lot of these studies have looked at specific groups of Black immigrants, since there's no comprehensive sort of national surveillance of the cancer experiences of Black immigrants as a whole. Reversing the increasing risk of cancer among immigrants in general as they adapt to life in the United States is really dependent on improving our understanding of barriers to early detection and prevention. So some previous studies have looked at barriers and facilitators to cancer screening among Black immigrants from the socioecological perspective and also the social determinants of health, which I'm sure many of you are pretty familiar with, being that we're healthcare professionals, or at least public health professionals and health researchers. So I will highlight a few of the factors associated with cancer screening among Black immigrants and then talk about sort of the research gap in this area. So starting from the individual level, we know that issues such as knowledge, attitudes, and beliefs about cancer screening are related to screening or whether or not immigrants engage in screening. So for example, immigrants tend to have fear of the unknown. For women specifically, or immigrants that are religious, the issue of embarrassment or modesty in interacting with a healthcare provider of the opposite sex may influence whether or not they engage in cancer screening. There are also issues related to cultural and fatalistic beliefs for certain Black immigrants that come from parts of the world that tend to be very superstitious or tend to have certain cultural beliefs that often do not necessarily consider cancer screening important. In terms of healthcare access, specific issues may relate to the provision of competent care by a provider or the availability of an English translator a language translator when immigrants are seeking care or any type of preventive care. There may be some also practical challenges such as finding transportation for, to get access to care, arranging for childcare, or even finding time during one's busy work schedule to be able to schedule screening care for immigrants. And finally, I want to highlight the importance of acculturation in that as immigrants adapt to life in the US, factors such as being a citizen or having lived in the US for many years or English proficiency are all salient issues that may impact individuals' ability to engage in cancer screening. Of all of these perspectives, one factor that is really important to point out are the interpersonal level factor, which is really considered the social context or the social experiences of immigrants as they adapt to life in the US. We know that the social context is really critical for discerning how behavior norms such as cancer control efforts are adapted and maintained. However, there's really very little research examining the social cultural factors such as immigrant networks or support systems that may serve as potential barriers or facilitators for to cancer control behaviors among immigrants. And so here, I want to move on to focus on one aspect of the social cultural context of immigrants, which is social networks, and pretty much describe what I mean by social networks and how that relates to immigrants in general. So in terms of social networks, and more specifically personal networks, I'm referring to the web of social relationships or the social ties that an individual may have. So social network may tends to be considered as having a structure and a function. So social network structure may be the type of the types of networks that an individual may have, or the type of individuals that may be within one's network. So this may be, for example, family members, friends, and neighbors. The size of one's networks or the frequency of interaction with network members are all considered the structure of one's social network. These networks are oftentimes relevant in terms of the types of resources that network members exchange amongst each other. So in terms of exchange of resources, network members are able to serve different types of functions, which may be in the form of social support, or network members are also able to influence each other in terms of the type of behaviors that network members engage in or are considered appropriate for network members to engage in. Prior studies have shown that network characteristics in general are associated with different types of health behaviors. Some examples include physical activity, engaging in healthy dietary practices, or engaging in substance abuse. All of these health behaviors have previously been associated with different types of network characteristics. In the case of immigrants in general, immigrants tend to have a unique network structure in that immigrants' network may actually be dependent on oftentimes their reason for migrating to the United States. This may be to work or to come here for education or to live with family members. Also, depending on how sort of the situation in which immigrants find themselves when they initially migrate, such as migrating to immigrant enclaves or finding themselves isolated in certain parts of the states, all of these may shape their network structure. We also know that the network of immigrants in general tend to evolve with time lived in the US, as in the longer the immigrants live in the US and they adapt to life in the US, the structure and the function of their networks tend to evolve as well. What we really don't know is how the personal networks of these immigrants may be associated with and ultimately may be potentially leveraged to increase cancer screening adherence. So previously, research has shown that personal networks characteristics are associated with cancer screening. So some research that examined network size and social connectedness found an association between these network characteristics and screenings, including breast, cervical, and colorectal cancer screening. So here by social network connectedness, I'm really referring to how integrated an individual may be in his or her network as opposed to being socially isolated. What the literature really lacks is studies examining the social networks of immigrants in relation to cancer screening, and especially these types of studies are lacking among Black immigrants. So one may ask, why is it even important to focus on foreign-born Blacks? Well, I propose 3 important reasons why it's important to focus on foreign-born Blacks. First, we know that previous research has focused on other immigrants, such as Latinx population and also Asian immigrants. However, very little work has been focused on Black immigrants in general. Also in the United States, health inequities, as most of us are aware, tends to severely affect US Blacks in general. Since US Blacks are not homogeneous, it's really important to understand differences between different groups of Blacks in the United States. And finally, as I mentioned earlier, that the immigrant health advantage that most immigrants tend to have upon migrating to the US really tends to decline over time. It's really important to also understand why and also what the process is for this decline among Black immigrants. This type of research would be useful in finding ways to ultimately prevent the decline in the positive health advantages experienced by Black immigrants. And hopefully this type of research would also inform health disparities research in terms of figuring out potential interventions that may further improve our efforts to reduce the health inequities experienced by Blacks in the US in general, and ultimately, hopefully also address issues related to the negative health experiences of immigrants in general. So as you know, as the title of my talk indicates, my study population basically focuses on Black immigrants. And so by Black immigrants, I'm basically referring to both voluntary and also refugee or asylee immigrants. Voluntary immigrants are basically immigrants that come to the United States for work, for education, or to live with family. Refugee or asylees tend to come to the United States to avoid conflicts in their countries of origin. These immigrants tend to migrate to larger cities or cities that are often welcoming to immigrants, particularly refugee and asylees. So my study population of interest in general has been North Carolina. And North Carolina is a unique state in that about 8% of its population are immigrants. And also it ranks 10th among states in the United States that actually are welcoming or accept refugees and asylees yearly. Also, one thing to point out about the state is that because it is a southern state, it presents a unique opportunity to understand the experiences of Black immigrants and immigrants in general residing in a part of the country that is often understudied when it comes to the experiences or the health experiences of immigrants in general. So my study objectives were as follows: to understand the role of social networks in cancer control and prevention behaviors among Black immigrant women living in North Carolina. This would be accomplished by examining the association between social network characteristics and cancer screening and HPV vaccine uptake. Here, I want to quickly point out that I don't really focus on the HPV vaccine uptake in this presentation, but I'm happy to take questions related to that. And secondly, to explore how personal networks of the immigrant women may influence their ability to navigate and access cancer control services. In order to basically accomplish this study, I used a mixed methods research approach, whereby the plan was to sample 300 women using a convenient sampling approach. I designed a health survey questionnaire, which basically examined women's social network characteristics as well as their health experiences as it relates to cancer screening. I also designed an interview guide to basically interview 20 of the women that would be surveyed to essentially explore their perceptions about cancer control and prevention, their previous experiences with cancer control in their home country, their social network ties and interactions, and also the role of their networks in promoting health-related knowledge, access, and support to preventive services. The immigrant women that I focused on were between the ages of 21 and 65 years. And essentially, the plan was to recruit the women, consent them, and also administer the health survey via tablets or online. The individual interviews would be recorded, and ultimately participants would be incentivized for taking part in this study. Here, we quickly want to sort of point out the importance of community engagement in this type of work. Immigrants in general tend to be a very hard to reach population, and Black immigrants in particular are especially hard to reach in that Black immigrants also are not necessarily homogeneous. That there are immigrants from the Caribbean and also immigrants from Africa, as well as other parts of the world. And although in North Carolina, there are specific areas in the Triad and the Triangle area where Black immigrants may be found, in order to gain access to this population, it's really critical to establish rapport with immigrant serving organizations, community leaders, and key community stakeholders that are actively involved in advocating the interests of Black immigrants. So some of the work efforts that I basically used were to interact with the Center for New North Carolinians that is based out of the University of North Carolina, Greensboro. I also interacted with the African Services Coalition, the Church World Service, and other key community members that were involved in the Black immigrant community in general. This process actually took me over a year in terms of really getting to know the key individuals that were part of the community, and also finding ways to begin to interact with community members. So by the time that we were ready to start our data collection, and this took some doing, but finally we got the approval to start the data collection. But unfortunately, a week before we started the data collection, the pandemic essentially shut the country down, which meant that all our data collection efforts and plans were stalled. So on my part, I had to quickly regroup and come up with an alternative to implementing my data collection approach. Ultimately, I decided to enlist the services of an online survey company that would collect the data on my behalf. After a series of conversations with the company and basically informing them of the challenges that it would take to really access this community, at least I felt comfortable enough to allow them to engage in the data collection on my behalf. Throughout the process, we experienced a series of challenges. I will highlight just a few here. So we initially focused our data collection to target just Black immigrant women in just North Carolina. But we could quickly realize that it was very difficult to collect surveys among immigrants in this state. So we had to expand our data collection to other southern states. The first round of expansion, which included Georgia, Florida, and Virginia, resulted in a few more survey responses, but this was still not enough. So later on, we had to even expand our survey to cover a few more states, which ultimately allowed us to receive about 200 responses. Here, I want to also quickly point out that the qualitative data collection is pending and is planned for late this spring or later on in the summer. To quickly move on, I will describe some of my methods. I'll describe the measures used for the findings that I present today, and then later on talk about a few more of the challenges related to the data collection. In terms of the outcome measures, as I mentioned earlier, the focus was on cancer screening, so we examined breast and cervical cancer. I will only present my findings on the cervical cancer, and I'm happy to provide some more information about breast cancer later. In terms of the independent measures, I utilized the Berkman and Symes Social Network Index. So there were specific social network characteristics that I examined. First, I examined the social connectedness. I examined social connectedness, which is basically a composite of network frequency, the types of networks, members in one's network, whether or not participants were married, and also membership in religious or other social organizations. I ended up dichotomizing this variable as high social connectedness or low social connectedness. I also examined contact frequency, which represents the number of friends or relatives that individuals had contact with at least once a month. I also included social support measures, which were a total measure of an overall measure of social support, which were categorized into high, medium, low social support. I also examined screening help, which represents participants' perception of whether there were friends or relatives who would be able to provide them with support or help in getting cancer screening. And finally, advice support, which basically represents the number of friends or relatives that participants perceived would be able to provide them with health-related information or advice. Additional covariates for this study included health access variables, which were health insurance and also self-rated health status. I also included demographic variables such as age, education, and income. And finally, acculturation variables, which were specifically whether participants were citizens and also the length of time participants have lived in the United States. In terms of the data itself, I mentioned earlier that we were able to receive about 200 survey responses. Here, it's important to also point out that some of the challenges with this data was that the first initial data that we received basically presented a few discrepancies or a few inaccuracies that resulted in me having to throw out about a third of the sample because it was really unusable. Some of the reasons being that a lot of the study participants who indicated that were foreign-born actually were not foreign-born. So one specific example being that a number of the study participants indicated that they were from the country of Georgia as well as the state of Georgia. But fortunately, because I had a series of questions that allowed me to determine whether participants were truly immigrants or not, I was able to really identify any discrepancies in the data. So once all of these data quality checks were conducted, I ended up with a small number of sample size. We did another round of data collection, which yielded more data, but the sample size was still well below the projected 200 sample that we ultimately had planned to utilize. So for my analysis, I conducted some basic descriptive statistics and also tests of association between network characteristics and cancer control, well, cancer screening, and more specifically cervical cancer screening in the form of pap test screening. So for my results, I will begin by talking about some of the personal characteristics of the women. On average, the Black immigrant women in my sample were 39 years of age. Less than half of them were married. About 80% of them indicated that they had at least some college or a 2-year college degree or higher. Half of these women had at least a 50,000 or more annual income, and about 2/3 of the women indicated that they were citizens. The average length of residency for women was 22 years, and also 85% of them indicated that they had health insurance. In terms of the social network characteristics, about 69% of the Black immigrant women indicated that they had high social connectedness. And again, this basically means that they were highly integrated into their social networks. Most of the immigrant women indicated that they had at least 3 to 5 network members with whom they had a monthly contact with. Most participants, which is about 43% of them, indicated that they had low social support, but as you can see, a majority of them had medium to high social support. In terms of participants' perception of having friends or relatives to provide them with support to get cancer screening, most of them, or at least half of them, indicated that they definitely had somebody to provide them with screening support. I ran a test of association between the social network characteristics and health status factors, and found that social connectedness and health insurance were significantly associated with pap test screening. And here I quickly want to point out that by pap test screening, we measured whether or not women were up to date with pap test screening. I then also examined whether social connectedness was associated with pap test screening using logistic regression analysis. And I did this examination in order to determine whether the social network characteristics and the health access characteristics that were not significant in the previous association, whether they may ultimately have some type of interaction with social connectedness. So in terms of the first model, I examined the relationship between social connectedness and pap test and found that women who had high social connectedness were 2 times more likely to be up to date with pap test screening compared with women who had low social connectedness. I later on adjusted the model with the demographic variables and found that the relationship remained significant. Therefore, in the second model, I controlled for all the network variables and found that the relationship between high social connectedness and pap test remained significant. In the third model, I included the health status variables, that is health insurance and health status, and found that the relationship between social connectedness and pap test screening was completely attenuated. And so here we suspect that insurance, which is considered one of the most important determinants of cancer screening, may have mitigated the relationship between social connectedness and pap test screening. So now I want to provide some context for these findings. In terms of the personal network, the personal characteristics of the sample population of the study sample, as you would recall, most of the women in my sample had a pretty high socioeconomic status. A lot of them also indicated that they were acculturated to the extent that they have lived in the United States on average 21 years or more, and also most of them were citizens. So this comes as no surprise that a lot of these women also indicated that they had they were up to date with pap test screening. The rate of pap test screening in this sample is also much higher than previous studies that have examined the prevalence of screening among Black immigrants. In terms of the social network index, a significant proportion of the sample indicated that they were highly socially integrated into their networks. And this may be due to the fact that most of these women have lived in the US for many years. And also we found that a substantial proportion of immigrants reported that they had low social support. This was about 45% of these women. Although the women also indicated that they were confident that there was somebody available to provide them with support if they needed to get screening. So here, the finding is not necessarily representative of what we found in previous studies examining the relationship between social support in general and cancer screening. So further work needs to be conducted in terms of the relationship between social support and cancer screening. And finally, I also want to point out that the sample that I used in my analysis is unique to the extent that it does not necessarily represent the Black immigrant population residing in North Carolina. For one, the Black immigrant population in North Carolina includes both voluntary immigrants and refugee asylees. In the sample used in the analysis, we were unable to really capture any substantial proportion of refugee asylees due to the difficulties in being able to administer the survey. And also, although previous research has shown that in general, Black immigrants tend to be highly educated, the sample in North Carolina, or basically focusing on North Carolina, would have enabled us to gain a more varied demographic of Black immigrants in the state, which would have been more interesting in terms of being able to understand differences among Black immigrants in general that live in the States as it relates to their cancer screening experiences. In terms of some of the challenges that I experienced in implementing this data collection and also this study specifically, I mentioned earlier that this population of Black immigrants are just really hard to reach. So there were a lot of data collection challenges that I had to contend with even before beginning my study implementation. But unfortunately, the pandemic made things even worse in terms of not being able to prepare for some of the unforeseen challenges that we experienced. One quick example being that a lot of these immigrant population in the state, especially the refugee asylees, tend to have limited access to technology. So the inability to reach these type of immigrants basically limits the scope or our ability to collect data from a wide range of immigrants with different experiences. In terms of the data itself that we used, I mentioned earlier too that a pretty substantial proportion of the data ended up being unusable because of the fact that we weren't able to really capture a lot of the Black immigrants that we were hoping to. And so a lot of the unusable data ended up being discarded, which meant that my sample size was much smaller than we had initially intended. Some of the limitations related to conducting any type of survey research also applies to this study, to the extent that since I used a convenience sample, it's impossible to generalize my findings to the general Black immigrant population and also Black immigrants living in North Carolina. And also because the data was self-reported, there's also potential for recall bias. Some future direction issues to consider moving forward is that a lot of the lessons learned in this process of planning and implementing my data will be very useful in my future research endeavors to work among Black immigrants. I plan on collecting qualitative interviews among immigrants in North Carolina later on this spring and summer. So a lot of the lessons learned will be very informative in terms of how I approach my data collection process. One factor, for example, will be the use of language translators and being able to make sure that I'm able to recruit women who may not necessarily be may not necessarily be fluent in English or have English as their first language. And also, I have still been in the process of enlisting more community buyout, and to the extent that I still am in contact with a lot of key community organization and members that have been very helpful in providing me with input about how to best stay connected with the Black immigrant community. So now I quickly want to conclude by basically reiterating that this findings essentially suggest that social networks are very salient in the cancer screening experiences of Black immigrants. And based on this finding, it's really important to continue to identify other network characteristics that may be associated with cancer screening. For example, network diversity or network multiplexity may be important to examine in relation to cancer screening. This study of networks and cancer screening is really important to the extent that identifying aspects of network of women that are useful or in promoting cancer screening can help us ultimately design some type of intervention or program that can help facilitate women's ability to engage in cancer screening behaviors. And finally, I also want to mention that based on our findings of the importance of social support, or at least the lack thereof from this specific study, future qualitative research would really provide us with more information in understanding how women's social support may also ultimately be useful in helping facilitate their use of cancer screening in the future. So on that note, I would like to end here and once again say thank you for the opportunity to give this presentation, and I welcome any questions.
Thank you. And as a reminder, if you have any question or comments, you can use the Q&A feature in the bottom toolbar, or you can use the raise your hand feature to be requested to be unmuted. So I have a question. You talked a lot about, your next steps with the doing additional research and kind of those struggles that you had with the type of research you had to kind of convert to with the move to online type of data collection. And so how, could you talk a little bit about kind of your thoughts around, moving forward? You said in the spring and the summer and that type of data collection, and how kind of what you think is going to be happening around your questions and the data collection.
So from speaking with a lot of the sort of community immigrant serving organizations, one of the things that I kept running into is the fact that there are other priorities, especially in this past year, that immigrants, Black immigrants or immigrants in general are facing or dealing with. And so in terms of being able to approach immigrant community, it's really important to also find ways to contribute to addressing some of the priority needs of these immigrants, while also, mentioning the importance of what you're doing, and also recruiting them to engage in the basically survey responses. So some of the things that we talked about, or some of the ideas that I got from speaking with different folks, is the fact that number one, offering sort of to present information that is salient to Black immigrants. So health-related information. We know that COVID is definitely the one important sort of issue that a lot of people need information about. And so dispelling myths or misinformation about COVID is one way to really gain more access to the community, and that we're able to provide them with relevant health information that is useful to them, while also engaging with them to provide the opportunity to present, what we're doing, and basically recruit them to, or invite them to take the surveys and also participate in the interviews.
Thank you. Another question we have is, what role do you see community health centers play in increasing cancer screenings in Black immigrants?
Community centers definitely play a huge role. Especially in the Guilford, the Triad area, which includes Guilford, that area has a pretty big or substantial immigrant and also Black immigrant community. And there are some health centers that specifically cater to the needs of immigrants. And so those types of centers ultimately try to provide a wide range of services to immigrants. But the question being, what role do community health centers actually play? Community health centers play a huge role to the extent that, well, being able to sort of collaborate with them to highlight the importance of making sure that cancer screening is one of the main services that they provide is very important. It's really an endeavor that hasn't really been done, especially in this area. So being able to do that and finding ways to support the ability to do that is something, or at least an approach that could be used. It's just that these centers oftentimes are stretched in terms of the type of services that they're offering to immigrants in general. So highlighting cancer screening as one of the most important, or one of the important preventive services that they need to provide for immigrants is something that would have to be done at least from a collaborative approach. It's pretty circuitous way of trying to answer this, but essentially the point is that community centers do a lot. And so it's important to also work with them to highlight the need to promote cancer screening among immigrants in general.
Another question we have is, what's your plan for how you will measure diversity among social networks?
So in the first round of the data collection, or at least in my survey, I didn't include social network diversity or network multiplexity. There are actual measures of measuring tools that exist to allow us to do so. But for this round of data collection, due to the fact that we wanted to basically limit the number of questions in our survey in order to encourage more people to take the survey, we didn't really use a lot of network measures. So our next step would be to basically do a larger study that allows us to measure different aspects of immigrants' network in general.
If there are any questions, you can use the raise your hand feature or type it into the Q&A feature. If there are no other questions, thank you everyone for joining us today. And thank you, Dr. Cofie, for this great presentation and information on this topic. Really appreciate you coming and join us. Our next seminar is going to be on April 14th, and you'll be receiving an email if you're joining us as an attendee today, where you can go to our website and see all of our upcoming seminars. And we'll also have the recording of this available as well. Thank you all for joining us today, and have a great day.